Good afternoon. Thank you for inviting me to come along and speak. Where's the clicker? Is this it? My name is Joanne Protheroe. I'm Professor of General Practice at Keele Medical School, NHS Clinical Advisor for Health Literacy and Chair of Health Literacy UK. But more importantly, as Kirsten says, I'm also a practicing GP. And I'd like to talk to you this afternoon about the development of health literacy research in the UK, really. And I'm going to start, and I was struck by the similarities between my pathway to health literacy and Kirsten's. I started as a researcher. I moved to Manchester in the northwest of England to begin my PhD in the early 2000s, and my background, like Kirsten, was shared decision making. I was doing a randomized controlled trial of a computerized decision aid, and I was practicing in that practice there in a very deprived, inner city, socioeconomically deprived area of Manchester. And it was whilst doing my randomized controlled trial of a decision aid, getting the qualitative feedback from the patients, receiving thank you cards from patients who were engaged in the trial and saying, I've never before been able to talk to my gynecologist, and now I feel I can talk to them and say what I want to have instead of just going with the flow. It was all of that, and at the same time, my clinical experience of working in a very deprived area of Manchester that made me realise that key to shared decision making was health literacy. This was my light bulb moment, if you like. Because you can't, and this is the WHO definition, you can't get engaged with shared decision-making if you don't have access to and understand the choices and the options that are available to you. In fact, it's really clear in this WHO definition that health literacy is the personal characteristics and social resources needed for individuals and communities to access, understand, appraise, and use information and services to make decisions about health. It's clearly absolutely fundamental to shared decision-making. So that was where I started, but at the time, the policy in the UK was very, very much about patient choice, about the self-management of chronic disease, about patients participating in their own care. Suddenly went off, did it? Oh, about patients, and health literacy was just not on the agenda. So the only way for me to get health literacy out there was to try and engage with this and my research was about demonstrating that there was no way for patients to participate in their healthcare or choose or get engaged with self-management or any of those things unless they had health literacy. But still, the UK policy was very much around patient choice and patient agenda. At the same time as starting to push on that policy, myself and Jill Rowlands, developed a community of action around health literacy. We developed the Health Literacy UK group that I mentioned that I'm now chair of, and it's now got 800 members. But at the time, it was just started as a special interest group of the Society of Academic Primary Care. And what's nice about this special interest group or this community of practice is that it includes practitioners in the field, educators, health and social care workers, and researchers and academics, and that's carried on. As time went on, the research output that comes out, a little bit like Michael was saying, was all around the effect of health literacy on health outcomes. It was all about how bad health literacy was for your health, basically, or poor health literacy was for your health. Lots and lots of studies were coming out that were saying that basically if you had low health literacy... Whoop. Yeah, I didn't do that. That if you had low health literacy, your health outcomes and your mortality were worse.
Okay.
Right, thank you. We were still having trouble, though, in the UK getting research funders and policymakers to take us seriously. There still was this overriding idea that this was a small problem, that perhaps a few people who had trouble with reading and writing were having, but not really anything to bother the policymakers. And if the policymakers weren't bothered, then the research funders aren't going to fund it either. What we struggled with in England was we didn't have anything that said how big a problem it was in England. The US had a lot of surveys, Australia had a survey, Europe had a survey. We didn't have one in England, and we couldn't get it funded either because research funders weren't going to spend the money when they didn't think it was a big problem. So what we did, Jill Rowlands and I, is we did a study to try and look at it on the other side, to try and show that, okay, we can't count exactly how many people have low health literacy, but let's look at the complexity of our health information. So we looked at all the health information that's out there in the UK, and by that I mean simple health information, the very broadest nature of health information, the instructions on the bottle of a children's syrup for paracetamol, how many mils you need to take per kilo of child, the instructions to fit a car seat in the back of the car, the instructions for the fecal occult blood screening, the bowel cancer screening that pop through the letterbox of all of our patients or citizens over the age of 60. Those instructions, those health materials, and we asked our national curriculum people, the ones who are responsible for saying the reading age of exams in the national curricula, to see how complex that information was. Then we compared the complexity of the information with the skills of our working age population. We had a recent survey, or recent to that time, it was 2011, survey of the literacy and numeracy skills of the adult working age population in the UK, or in England. And we found, as I'm sure won't come as any surprise to the people in this room, that the health information was too complex for 43% of people aged between 16 and 65. And if that information included any maths, so the numbers on the side of a bottle of children's medicine, mils per kilo, then it was too complex for over 60% of the population. In England, our working age population is over 34 million. So that means that somewhere between 15 and 21 million people of working age across the country may not be able to understand and use the information they need to look after their health. So now we had numbers. And this had a massive impact. This ended up being splattered across the local and national press, local and national radio. Jill and I presented the results to the House of Commons. I was interviewed on breakfast television. It's one of my highlights. So it really did make, it created a sea change. This work was 2013. The paper was published a little bit later, but the work was 2013. And following that sea change, we started, I'm not saying I'm responsible for all these policies, but I think it just contributed to a change in policy and the feeling in the country. And we started to get policy documents coming out. That one on the top left is Scotland. Then we've got Ireland. This one down here with the hexagon, that's Wales. This is NHS England. Policymakers started to get it, and with that follows some research funding, we hope. It's slow, but, you know, it does happen. Locally, I've now moved to Stoke-on-Trent in my career. Locally, I had engaged with our City Council and Public Health Department in Stoke-on-Trent, and they were very enthusiastic. They got it in local City Council, so local policies were able to change. We had several town hall meetings, and we came up with an agenda for change within our council. And out of this, these are just some of the ideas that local people came up with to make small projects, changes to what they're doing in their daily practice. Lots of little local projects came up from the grassroots level that were taken up on board. So just a reminder, you've seen this slide or versions of this slide lots of times before, but thinking about now that we've got health literacy on the agenda, what do we do about it rather than just say how terrible it is? It's not just all about doom and gloom. We need to think what we're going to do about health literacy. So this representation of health literacy, this balance scale between the skills and ability on the one hand of the patient and family, and the demands and complexity of the system on the other hand. So what we can do then is try and reduce system complexity or the service demand, reduce the risk of low health literacy, if you like, or at the same time, we can build skills in our individuals and communities to increase the health literacy asset. This was a project that was done by NHS England as a demonstrator site where we attempted to do both. NHS England had started taking it seriously, appointed myself and Jill Rowlands as NHS clinical advisors, and came up with this demonstrator project where we trained health literacy, we gave health literacy awareness courses and trained our health professionals in symptoms, things like teach back, and ways to manage poor health literacy in patients and recognise it and deal deal sympathetically with it. And at the same time, we put on some skilled health courses for patients. This was a validated health course for patients with poorly controlled diabetes. It was evaluated locally at NHS level, and it was shown that it successfully increased patient knowledge about their diabetes, it improved their medication management, and improved their use of health services. Unfortunately, and this is common, I think, when you get policy changes or NHS, certainly it's common in England, you get these little grassroots projects and things. There was no funding or time for formal research evaluation, and therefore there wasn't any cost-effective evaluation, which I think is a real problem, and that's one of the benefits of the lab and the hub being together, is that if you have these co-designed grassroots projects, which are really important when you've got engagement from your local professionals, you need to be able to you need to be able to robustly analyse them so that as soon as the money gets tight in the system, these things that are considered just nice to have but not essential are the first things to go. So I'd just like to finish in this second half of my presentation by just telling you about a few projects that I'm involved with that are research-funded projects. And I've divided them into that balancing service complexity, service demand, and then the skills one. So just a few examples of projects I've got currently on the go. We're looking at whether or not we can identify patients with low health literacy from routinely collected practice data. I've been in a position to insert subtly and secretly health literacy measures in lots of cohort studies in my School of Primary Care Centre. So we've got an awful lot of secondary data about people with low health literacy, and we also have matched medical record data. So we've been able to use all of that in secondary analysis to come up with a proxy measure for health literacy that we hope that you can just pop up onto the electronic medical record of patients when they come and see their healthcare professionals. We've taken this one step further where we've combined this alert that pops up on the screen with practitioner training and with the clinical generated alert to improve general practice for patients with low health literacy. So the alert pops up when the patient comes to see the nurse or the doctor for a long-term condition review. And then the GPs and practice nurses have been trained in hopefully, in health awareness and health literacy awareness and techniques. So this is ongoing. So we hope that that will lead to some behaviour changes and some improved health outcomes. The final system complexity service demand study is where we're looking at one of the early papers that I flicked up when I was telling you that the NHS were only interested in self-management and patients looking after themselves, thinking, of course, that this would save money for the NHS, is that we found that currently supported self-management for people with musculoskeletal pain is not suitable for people with low health literacy. So we're trying to develop interventions that are suitable by using stakeholders and patients with low health literacy. We do that. So on the other side of those balance scales, the skills and assets base, asset building, we've got a project looking at childhood risk factors for low health literacy in adults. So it sounds back to front, but what we've been able to do is insert a measure of health literacy into the Avon longitudinal parents and child questionnaire. I can't remember what the S stands for, but it's a birth cohort. And what we're trying to do there is we've got the health literacy measure into these people who've been followed up, who are now 24, and they've been followed up since birth. And then we're going to retrospectively analyse the childhood factors to see if we can find any possible predictors of low health literacy by the time they reach adulthood, and identify possible points at which to put in preventative measures or skill-building interventions. So that also is ongoing. We're also looking at the way that we explain conditions to patients. Looking at osteoarthritis, for example, it's a really contradictory thing to tell somebody with a pain in their knee that they need to go out and exercise more. And patients, for quite reasonable reasons, don't understand it and don't get it and don't exercise. So we're clearly not explaining it very well as health professionals, so we're going to have a look, see if we can improve on that. And then finally, something that we've got in for funding at the moment is an interdisciplinary PhD to look at mental health literacy among children and teachers in schools. So across the life course, to try and see if we can develop some interventions from the school teachers and the children together to co-design an intervention. So all of those, that's an example of a few interventions that my team are currently involved with, and I just wanted to finish with saying, well, you know, is there any point? Do these interventions for health literacy actually make any difference? They do, in the short. This was a report by Public Health England where they looked at improving health literacy to reduce health inequalities. This came from Michael Marmot's team, so there's another link with Kirsten. And they showed that efforts to improve health literacy have a range of benefits. They increase knowledge and build resilience. They encourage positive lifestyle change, empower people to effectively manage their health, and decrease the burden on health and social care services. The available evidence suggests that strategies to improve health literacy are important empowerment tools which have the potential to reduce health inequalities because the most vulnerable and disadvantaged people in society are at risk of limited health literacy and are known to have the poorest health outcomes. Other systematic reviews have shown that improving health literacy improves medication, improves self-management of conditions, reduces reported disease severity, reduces unplanned hospital visits and hospital use. So yes, interventions do work. So what do we need to do better? Well, we need to continue to build assets and decrease risk in the interventions that we're developing. We need to explore health literacy across the life course, more health literacy in schools, skill building in vulnerable groups, building health literacy training to undergraduate curricula of healthcare professionals, looking at our built environment, complexity of our systems, and most importantly, when we get those grassroots projects and co-design projects, that we robustly evaluate the cost effectiveness so that we can produce evidence for policymakers and funders. And I think we need to think hard about our research design. Too often we rely on randomized control trials, and I'm no different, but randomized control trials take too long to make any policy change. They take 3 years, so we need, take at least 3 years, sometimes longer, don't they, by the time they get into action. So we need to think of other research designs. Thank you very much. Thank you.
Thank you, Jo. Does anyone have any questions? Over here.
The one we put in the birth cohort study was the European Health Literacy Scale. I don't know if you've seen that one. It's got a 48 measure version and a 16 measure version and a 6 question version. I think that you have to pay to add things into birth cohorts. I think we managed to get, I can't remember, we might have managed to get the 16 measure version in. But they're already a lengthy questionnaire that these guys have, so... But it's exciting. We haven't got the results back yet, but we did get, I think, 8,000 questionnaires back, so that's very exciting stuff.
Any other questions? Lyndall.
Hi, thank you. That was a really great talk. Thanks, Jo. So I work as a GP very part-time, working with refugees, and all of our patients pretty much have low health literacy, and most of them also, you know, have PTSD and layers upon layers of complexity, which I'm sure you're familiar with. Every once in a while, though, I find somebody who's incredibly knowledgeable about one condition. I'm thinking of an African woman who is HIV positive. Blow me down. I mean, she knew all about CD4 counts, she knew all her medications, she knew the doses and complex double-barreled names, and, you know, this was really quite a surprise to me. And yet she knew pretty much nothing about her reproductive health. She knew almost nothing about healthy diet or lifestyle. Understandably, she just arrived in Australia, so I wouldn't expect her to understand about our health system. But, you know, I mean, even just basic day-to-day things. And it occurred to me that she actually talks about asset building. She actually had quite good assets there to build on, but it seemed to be stuck in one disease, that she'd obviously had quite a lot of good education back in her home country. I'm just wondering if you've experienced anything like that, if you have any thoughts or comments about how we can get that sort of knowledge to spill over into other aspects of health and life in these people, so we can add value to what they already know.
I have had experience of that. I think it's quite common. I think Don has a slide that health literacy is context specific. So it's quite common. You get somebody that's grown up with diabetes, and by the time you meet them as a young adult or older adult, then they know diabetes inside out and back to front, just like this lady you've described with her HIV. But then, you know, they get COPD at a later age and they're completely knocked sideways by that. And I think that's quite common. I don't have any answers about how you transfer health literacy skills across from the other, just that I suppose that as practitioners, we shouldn't be fooled into thinking people are health literate because they're very consummate about one particular health problem. We need to always just take almost, if you like, a universal precautions approach to each new symptom and condition, and be open to questions and using those techniques.
Thank you. I think